you, the taxpayers of the United States of America, without whom we would not have this course. So to sort of set the stage for this, at this point in the course, we've been working to help you translate the great clinical experiments that you've designed in the earlier phase in the course into a motivational document to convince outside entities to give you the money you need to do the trial. The Dr. Silverglide, we used to have a combined session last year where we kind of talked about the specific aims and the rest of the protocol. Given the crucial importance of the specific aims page, as this is what many of the reviewers in the review panel, it's all they're going to see, we dedicated that whole session to that, and we'll have that uploaded to the website and internet soon if you weren't able to be on it. Here, we are working on describing to you what an approach is to describing the research strategy in your grant should be. And while this is targeted somewhat to the NIH and NINDS mechanisms, the general idea of translating a long protocol, which is the essence of creating a reproducible clinical experiment, into a relatively short motivational but thorough and complete document that allows reviewers to understand that what you're doing is well thought out and is going to move science forward, I think is really the key thing that you have to balance when watching this. I know that many of you have asked for more examples of research strategies, and since the format has changed in early phase clinical trials that have kind of underpinned some of our trials, we don't have as much fodder for that, but we're working on getting some things into the box, and we will have some examples there. I think one of the key things to think about, and this was brought up by Dr. Silverglide, is think about who your audience is and that you're communicating to the reviewers. But there are going to be, and this is going to lead into that first question. You have to understand that there are going to be two types of reviewers. The reviewers who really have expertise in your field and others who are experts in other fields. And you have to be writing a document that's going to have sufficient detail to satisfy people in the first category, but also isn't going to lose people in the second category. And again, you can look at this in sort of specialty specific ways. If you're a neurologist, a neurosurgeon is going to need to be able to understand this to a certain extent, depending on the study section. Somebody who does research in other diseases and other subspecialties is definitely likely to be on your review panel unless you're studying a very common disease. So those are important things to understand. I think one other thing that I would just recommend to you, depending on the mechanism that you're using, is taking a look at Project Reporter, which is a resource by NIH that you can search everything, all the grants out there that are funded. And that gives you, to a certain degree, an idea of what success looks like. The mechanism at NINDS for funding even early phase clinical trials is the exploratory R01 mechanism. Potentially, K23s can have clinical trials sort of embedded within them as part of the aims, although certainly unlikely to be the only aim of a K23 application. So I did a little digging on Project Reporter, and from the population of grants that are currently funded by NINDS, there's about 4,800 of them. 310 of those grants had the keyword clinical trial in them. Of those grants that had the keyword clinical trial, including this clinical trials methodology course, 115 of them were K23s or R01s, which would really be the relevant mechanisms for early phase trials, not phase 3 trials. When you look at those, somewhere around 12 of them, of those R01s, are actually a clinical trial. The other 95 or so are collecting data or doing experiments that are going to lead to a clinical trial, and that's what they've written, at least in the project summary and abstract. In the K23s, there were about 11 of them that had clinical trial as a keyword in their project summary or abstract. And about 2 out of the 11 that I saw, based on my very non-scientific, non-reproducible, quick looking at the narratives, did have a clinical trial in them. So this is not to dissuade you from doing clinical trials. I think it is crucially important. If 100, if over 100 of the R01s out there are saying they're leading to data in future clinical trials, it crucially points out that we need to be doing clinical trials. And just because there aren't a lot of them in Project Reporter doesn't mean you should be dissuaded. I think the key thing that we can do is one, also think about, for our early phase research, alternate mechanisms such as foundations, the AHA, the American Academy of Neurology, or other disease-specific foundations as potential avenues for the smaller early phase trials, but also to consider the R01 mechanism as the major platform for how a clinical trial, for most of you who would be being done at a single site, would be funded by NINDS. And again, I'm not speaking as by full disclosure, what I am saying does not represent the views of the NIH or NINDS. It reviews simply my observation of what is on their publicly available data. And again, you should always talk to a program official about things. But just bear in mind, many of the NINDS mechanisms say, do not submit a clinical trial to this mechanism. So they really do want them going through specific mechanisms, such as the R01, or through research networks for more of the multi-center trials, at least in a few areas. So with that, I think maybe if before I ask the formal questions, if I wanted to hand it over to Dave and Karen, if there was anything they wanted to build upon from what I just started out with, I will grant you the microphone, and whoever clicks it first can talk first.
Can you hear me? So I would just add that as you look at mechanisms to get funded, think about the timeline, because I know a lot of you, we just talked about this in our small group, a lot of you recognize that it's going to take you 1 to 2 to 3 years to recruit your patients, but don't forget that your clinical trial is longer than that recruitment period. So don't apply for a 2-year funding mechanism because you know you need 2 years to recruit your patients. If you need 2 years to recruit your patients, you probably need at least a 3 or a 4-year grant. So think about the timeline as well.
And I'll just comment a little bit on what you said, Will, about the number of clinical trials versus other R01 or other studies. And that's not surprising, right? Because the clinical trial is really the top of the pyramid. It's what everybody's working towards with all the other studies. Otherwise, we wouldn't be doing NIH type of work. So the clinical trial is once you've got all the data that you think is necessary to move forward, and especially the phase 3 clinical trials. So I think it's appropriate that there is a refined number of those compared to all the other grants out there. Plus, to be honest with you, they're very expensive, and NIH can't fund 100 and something clinical trials in neurology. So they're going to be very selective about those because it costs a lot of money.
Very true. Interestingly, if you did some limits on the Project Reporter website, when you look at, there are about 4,800 funded grants currently there. When you limit that to grants that have more than $200,000 a year in funding, both direct and indirects, that goes down to about 3,500. And then that total number of grants goes down to about 600 with 500,000 or more a year in total funding. And when you get right down to it, the number of clinical trials with 500,000 a year or more in funding is somewhere around 80, and some of those are actually infrastructure grants and so forth. So with that, I'm going to start with the questions. And again, if there are comments from the audience or questions want to build upon what we've been asking about, please feel free to put those over there in the chat box. The first question sort of goes upon what I was talking about before, And both from your perspectives as a reviewer on a study section and as a writer of grants, how do you balance writing for two audiences? The assigned reviewers who have expertise in your field and the others who are experts in other fields?
All right, I'll start. To me, it's very simple, and it's that, keep it simple. Even those people who, when I, for example, get a TBI grant or traumatic brain injury grant, it's so refreshing to see a grant that is clearly articulated and very simple, connects the dots between the hypothesis and the outcomes, and so I think what happens if you try to bury too much detail in there and make it look like to the reviewers that you're smart and you know what you're doing is a big mistake, and that that's people, the reviewers will see through that very quickly. But being succinct and being simple, keeping it simple, will favor you on both sides of this equation.
I would totally agree with that. I think that's the primary message, is to keep the information simple, concise, and linear. So remember, you're telling a story. So telling the story step by step in a simple way takes all of your reviewers with you to understand where the science has been and where it's going, and then you get everybody on the same page so everybody understands what you're thinking about. And then it doesn't matter that they have different levels of expertise, because you're telling your story and convincing them that this is a really important thing to do and it is the next logical step. So I'll say that a lot. Convincing them that it's the next logical step in the scientific step by step that has to happen. The other thing I like to see is, I agree with David, I like to see it very simple and basic, almost, I hate to say redundant, but having basic concepts several times in the grant. So saying it's important that we randomize patients in the background, and then in the methods, and then in the, the innovation or whatever. Having some of the same concepts again and again, I think, is helpful. The other thing I like to see is that I like to see people step it up in the potential pitfalls. So if you have a section of the grant where you can say, these are problems that I've considered might happen, that's a great place to speak to the folks that have a higher level of understanding about either your disease or your methodology. So going there and saying, I recognize that the limitations of PET scanning is X, Y, and Z. I might not understand the limitations of PET scanning, but putting that in there so that the radiologist on the committee sees that you understand that potential limitation becomes a really important kind of outlet to speak to that person, that you've at least considered that, and that you have a plan in case that problem happens. So I don't know, David, if you ever use the pitfall section, or if you like that when you're reviewing grants to see kind of a higher level of thinking, but I like it there.
Yeah, my grants don't have any pitfalls or limitations. No, really, I think that's good, because what you're doing is you're heading off the comments that are being typed in as the reviewer's reading the grant. And they're sitting there with a cup of coffee on the airplane, usually just before review committee, to be honest with you. And they're typing in the reviews, well, he didn't think about this, or she didn't do this, or what about this? And then when they get to the end and you sort of said, we recognize this, and not just that we recognize it, but here's how we're mitigating it. Either we brought in a whole group of advisors who are radiologists, and they're going to help us interpret this data, or whatever it is, how that you're going to address the problem. And I think, just to put another sort of concept in here, is kind of the death knell for some of these studies and these trials are, if there's an element within the study that the whole if it's a two-part study and you've got the second part dependent on the results of the first part, and that first part fails, then all of a sudden your whole study is a failure. So if that's the way your study is designed, which is not necessarily bad, you need to make sure that you have accounted for how you're going to deal with a failure in one or two parts leading up to the final conclusion. If there's a way around it, or just how you're going to address it. So I've seen a lot of times the reviewers really hit hard in some of these two-part studies.
I think that's an important point. The aims need to have some interconnection, but if they are conditional, like you must succeed in aim 1 to even start about thinking about aim 2, there is a risk there. I think the idea is if they are interconnected, but in clinical trials there may be elements of both feasibility and safety aims. And in contrast to some more preclinical experiments where clearly there's going to be some output from one aim that's going to inform the design of future experiments. When you're doing a grant that is describing a clinical trial, there's not going to be enough time for iteration. That the pathways have to be pre-planned, and sometimes that might involve an enrichment plan or something like that. Again, those are more complicated designs that, if we're not recruiting a lot of older adults, we may focus on younger adults. It depends, and again, you have to be wary of those sorts of things. But having having the pitfalls and the way that they're going to be addressed, I think, is important. In general, it would seem that one of the best preventions against one of the most common pitfalls is that you're not going to be able to enroll people in this study, or that you're not going to have a sufficient population. And I think one thing to sort of note is in the allowable appendices, or really required appendices for NINDS R01 exploratory grants, you do have a clinical trial protocol, and you do have a table that shows that you have access to the patients at the sites. And I think there's a major reason for that. I think the reason for the clinical trial protocol, and part of the reason we had you do that first, is you're using that as an appendix, and many grant mechanisms are going to allow you to put that whole protocol as an appendix. Doesn't mean that the reviewers are necessarily going to read every bit, but if they see that 50-page document is there with all the details, if there's something that's kind of like, well, what's going on here in the research strategy, they can go there to look. Now, that's a benefit or a curse. They may be mad that they had to go somewhere else to look, and that it wouldn't come through, or they may be happy that, oh, okay, they had enough to get me excited about this project here, but I'm really interested about this detail of how they're collecting outcome measurements. And you have that other real estate there to use, potentially the human subject section, to know that your consent process, your screening and enrollment is going to be equitable. There are ways to, and this is not meant to circumvent the 12-page limit at all. You never want to intentionally circumvent the page limits, but you do want to put additional information in other places where it can be a resource and augment that. I think Karen, anything you want to add to that before we move on to another question? Turn myself off. So I think the next question is, what are particularly effective techniques for summarizing a detailed protocol with many pieces within a 12-page, or maybe less for some foundations, research strategy? What are the key pieces of information that need to be communicated? What ought to be tabular? What might look nice as a diagram? Where do you see an efficient use of your limited real estate in terms of moving things from that protocol into that research approach space? I'll let Karen go first.
So I think this is a really key question, and probably most of you don't realize that we used to have 25 pages to do this, and now we have 12. So being thoughtful about this is really important. There are a couple things that I would say, and then I'll pass it to David to comment. But I think your preliminary data section is a really obvious place where you want to use tables, figures, graphics, get a lot of information in a concise way. But I will tell you, it is very risky if you're going to put data in a complex table or graphic and not make sure that every reviewer can understand how to read those data. So if you are going to use tables, graphics, figures, please make sure that you're not using abbreviations. I will tell you my experience is when people use a ton of abbreviations and I can't figure out what they mean, it's very frustrating. But also that you're labeling those figures and graphics very clearly. Every x-axis, every y-axis, every bar, every single thing that you can think of that I, as a novice reviewer of your work, may not understand what you're trying to demonstrate. If you can do that, and if you can show it to somebody totally outside your field and they understand what you're communicating in that table or figure, that's a really efficient way to use that kind of space. And again, I think preliminary data is a really nice way to do that. The human subject section, I'm hoping we'll talk about that in more detail. But I think that thinking carefully about what you can introduce in the body of the scientific methods section, and then what you refer to the human subject section for in more detail, becomes really important, because you unfortunately do not have time or space in your methods section to talk about all the detail that your reviewers want to know about how you're going to do this clinical trial. So we'll talk a little bit about that. The other thing I would say is that as a reviewer, I can tell you that if I glance at a grant and it's all words, and it's words packed in paragraph after paragraph after paragraph with no space, no break in the flow of the words, no graphics, no figures, you've already probably lost a fraction of me, because I know that I'm going to be exhausted by this grant. And I count on those spaces and those figures and those somehow break the flow of reading through that whole grant. So I would think strategically about the fact that you want to have some kind of non-text component to communicate your ideas at some point in the grant, and then figure out how to scatter those around. And David and Will can comment, but maybe it's because I'm getting old, but it's harder for me to read, just to stay attending to word after word after word without something else to look at.
Yeah, coming from Georgia, I'll reiterate that, because we use coloring books in our library, and I go by pictures. And so if you can't explain it to me in a diagram or picture, I'm certainly probably not going to get it out of words. Seriously though, I completely agree. Actually, another refreshing thing is when you open up a grant and there's really nice graphics and tables that kind of help walk you through the process. I think using a timeline where it shows very nicely and cleanly across an 8.5 by 11 page how the study is going to proceed, and where the different hypotheses are going to be answered and the outcomes measured and those kind of things. That's really very helpful. I actually like, I know it sort of sometimes takes up more space, but I think if you can do some bulleted sections where it's this, and this, and you're very clear, because all the adjectives and in a narration, you lose your point. And if you can say something succinctly in a bullet, then basically takes a paragraph away. And so I think even though it looks like it's going to end up using more of your space, the bullets can be very helpful. And a trick is actually, if you make a 2x2 table, you can actually put bullets across the page. So you could have 3 layers of bullet, or a 3x3 box table, and then you can hide the table outline, and the bullets show up in the nice formatting on Word. So you can kind of use tables to help lay out things, and then hide the table, and nobody would ever know that you put it in different boxes. So that's kind of one way to do that across a page without losing so much. I would caution about not including something that you're going to put in an appendix. The NIH harps on this, that the appendix is not to take the place of critical data that should go in the grant. I will second that, mainly because as a reviewer, when you're looking at these, the appendix that you look at is kind of a flip through, oh, by the way, or maybe I need to go to it to kind of help decide whether they're clueless in this particular section or not. But it's not something that I read with detail like I do with the 12-page grant. I mean, I read every single word, sometimes multiple times in the grant. The appendix or appendices are just going to be flipped through. So if it needs to be said, it needs to be in the 12th page, but you can refer. So if you say, you know, details about this protocol or this methodology are in the protocol in the appendix, that at least alerts the reviewer that, hey, if I need to know more about it, I can go there. But you still need to summarize it to the point where if someone understands that methodology, they don't have to go and dig it out of. You don't want to. So the bottom line is you don't want to piss off your reviewers. You want to make it as easy as absolutely possible for a reviewer to connect the dots. And you have all sorts of different types of reviewers, from neurosurgeons to neurology to emergency medicine to the stats folks who don't necessarily know the content. They don't understand the content to some degree. So all of that you've got to teach each person the same thing about your grant. And so it's, again, that's the purpose of the KISS principle, of keeping it simple, so that just about anybody can read. And you know, actually, one of the things that I do is, I don't do it with my spouse, although I've heard some people do, because she would hit me over the head with it. But have somebody who's not in your field read your grant will give you a lot of insight. And you'll have an acronym or something, and they'll go, "What the hell is this?" And so a lot of the reviewers do that. I mean, I'm sitting here, I'm looking at these. I get a Parkinson grant or something like that. I go, oh my God. And I'm sitting here trying to read all these different acronyms for shaking body parts and other things. And it just drives me nuts. So alleviate that and try to avoid a lot of acronyms and a lot of shortcuts that you're trying to use for your pages. Because it'll come back and bite you, I think. I would... Karen's point about making a point multiple times through the grant is good. Be careful, though, about redundancy. If you've sort of said how important you think this is 5 times, you probably wasted 4 times worth of space. And then I guess the other comment I would say is that 90% of negative comments about a grant from reviewers are made on the approach. So you need to focus your 12 pages on the approach. The background, we get these grants and there's like 4 pages of background, and then about a page and 2 pages or 3 pages of the approach. And then, you know, maybe that's backwards, because what you really need to explain clearly is that approach, because that's where you get dinged the most. And, you know, if it's made it to study section, and it's an important disease, you know, you don't have to reconvince study section that traumatic brain injury is an important disease. We know it. You do have to convince that the background of what your approach is important, but don't spend 3 paragraphs talking about traumatic brain injury and its significance. We get it. So that gives you a lot of room to focus. And I'll shut up.
So, Will, there's a question in the chat box from Andrea that you might want to address, because it talks about what David was just talking about, is how do you balance kind of the background section with the rest of the grant when you have a lot of background.
I think that is that really, I think he gave a partial response to that, or in that, and also the data from NIH peer review is that the thing that correlates the most with your final impact score is how your approach has been graded. Now, the other thing, though, and that's probably gonna, if there is a strong biological rationale, is extremely important, and it's become more important based on these recent initiatives, and that is not a bad thing at all. So being able to link the biology and the mechanism to what you are doing is an important part of the potentially the significance and innovation parts of the grant. Indeed, the background session is weaved into significance, innovation, and partially in the approach. So the idea of significance and innovation, again, the approach may have some aspects of the reasoning biologically why you are doing what you're doing in humans. Some of that may be part of the significance that this is how it's going. The old format had quote unquote background, whereas now the idea is that those things are weaved across. And preliminary clinical data from earlier trials is probably going to be either perhaps a little bit in innovation, perhaps a little bit in approach. And it sort of depends. I think it's the idea of telling a story, that you're making a linear, this is what we know, this is what we need to accomplish, this is why it's feasible for us to accomplish it, and now is the right time biologically for us to be doing this. So I think telling that linear story, along that end, I think one of the ideas of using headings, to a certain extent, you want, if somebody only reads your headings, they should have an idea as to what the story is that you were telling. And then they go into each of those paragraphs for additional details. So in terms of, I think the part of your question that is, how much real estate to dedicate to the preliminary stuff and the biological rationale versus how much to dedicate to the new experiments you're doing, I think those things are going to be correlated, but I think the most importance is going to be placed on what you are doing now. And you do have to set up that now is the right time to be doing what you're doing. But I think, I can't give any firm numbers, like make sure that 75% of it is going on approach. But that's, I think, I don't know if Karen or David has a more eloquent way of addressing that.
So I was just going to add to that. One of the things that I find that people get stuck on is, what do you put kind of in the background section and what do you put in preliminary data? So I generally tell people that I expect in the background things that are already published, they're established. So that background section should be a lot of kind of clear statements. The data has shown X, reference, reference, reference. So you don't have to explain all the data there. When you get to preliminary data section, that's the stuff that isn't yet published, and that's the place where I generally like to see people show the data more, whereas in background, I like to hear the kind of the conclusion from the data that's out there. I can always go pull the paper if I have to. Now, if you tell me that the paper proved something and I pull the paper and it didn't, you're probably done with me. Because then for the rest of the grant, I know I can't trust that you interpret the data well. But if it's in a guideline statement, the guideline statements clearly state that you're supposed to do this, and that's what the guidelines say, then you've just saved yourself a ton of time. So the other point I wanted to make relates to what David and Will were both saying about kind of bolded headings and bullet points. I find these really helpful, both as a reviewer and when I'm helping other people write grants and when I write grants. I also will often bold something that is critically important that my reviewer reads. So if I have a concept in the early part of the grant that is critical that my reviewer understands before I get to the methodology, like I'm just going to make something up. Children are different in this disease and children cannot be included. Let's say it's something like that. If that's critical to how I design my experiment, my trial, I may bold that early on so that even if you're glancing at the page, your eye is drawn to that statement. Hyperglycemia is associated with worse outcomes in acute stroke patients. That's a critical concept for me, so I might bold that statement in the early part of the grant, so I know you got it before you get to the later part of the grant. So you can't bold everything. You only get to bold a couple things. Innovation. Here's another trick that I would recommend you think about. You will likely know what the review panel is scoring you on. If you're submitting an NIH grant, there's a form that we have to score, and innovation is part of it, impact is part of it, significance is part of it, investigators are part of it. If you can bold those sections to give me the answer so I know what to put in my review, like, hello, innovation coming now, I'm going to describe my innovation, that helps me. Plus, if you can call attention to that, I'm likely to use your concept as I assess innovation, as opposed to me flipping through the grant at the end saying, I can't remember where the innovation is in this. Does anybody else want to comment on that? David or Will, do you guys do that?
You nailed it.
So I know, David, that you have another commitment and you're going to likely have to leave very shortly. Was there anything else you wanted to share before you had to split?
No, I just summarized, and I looked at your questions before. Again, is connect the dots for the reviewer, make the reviewer's job easy, and if someone outside your field doesn't understand the grant, then the reviewers won't either. And all of these principles that we've been talking about, bulleting and headlining, and clearly stating, from the review grading system where these different elements are. It's all about making the life easier for the reviewer, because if the reviewer really, if it's easy for a reviewer to get to it, it becomes refreshing. It's a positive attitude. We're human. We tend to like, it when it's given to us and something that's easy to digest. It's not to say that a dense grant is not necessarily going to be a good grant. There are some dense grants that people rave over because they are so spectacular, or because the problem is such a big issue and it really addresses it well. But those are rare. And I think if you make it easy for the reviewer to understand the concept, to know what you're trying to do. I think the other thing I wanted to say in here, and I can't remember if it was a part of this or the last session, which is the things that seem to make a lot of grants fail, at least in my book, is can they do it? And that there's a number of principles within that. One of them, of course, is do you have the sample size to do it? And not just can you say that you have the sample, but have you actually done it before? Or have shown that you actually can enroll these patients. In using the sort of what I call the 10% rule, and I don't, it's not my rule, but it's just one that I've read about. It's if you think you can get 100 patients, you can only get 10. And so it's just the truth. They all go away whenever you open the trial. I don't know why. They do. They disappear. It's like lights and cockroach. They go. And so just being realistic about how many patients you can enroll, prove to the reviewers that this is something that you can do. And if you're a new a new investigator, surround yourself by experienced investigators. That'll give a lot of confidence to the reviewers. But remember, just putting someone's name and their bio sketch in your grant is not really going to convince a reviewer that they're involved, that they need to have some sort of really integrated way that they're working with you. Like you've developed an advisory committee, and this person's the chair, and these 4 people have agreed. You've got letters from them to make sure that it's not some tacit engagement, and that they're really going to help you as an individual. And then I guess the last point I want to make is stats, 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 stats. So many times these grants are killed based on their statistics. And, MPH teaches you a lot about statistics, but you need a statistician on your grant if you're at this level. That's not a 1 to 2% of your grant, because that's the first thing the statisticians in the room do, is they look at the grant and then they're going to flip back and they look and see what % effort was the statistician on the grant. They don't even have to read the stats section to know how involved that person is in your study. And if it's just a 5% effort, you're done. I mean, they're just going to say there's no statistician involved in this study. And so, and if you have a good statistician, then your stat sections should be appropriate. So it helps on both sides. And I'll leave it at that. Oh, I got to turn my microphone.
So on the pending question, do we have ones to share in the 12-page format? We're working on it. I've done a solicitation. Since a lot of trials these days are team science and there's multiple PIs, sometimes this has to sort of like go through who wants to see what and et cetera. So I'm working on that in terms of having what the clinical trial grant proposals look like. I think it's interesting. I mean, the NIAID does have that nice website where they have grant proposals from some people they must have gotten permission from, along with the summary statements. Although they're all oriented towards really preclinical experiments. So that is a nice way of looking at people who have successfully communicated science, but not the exact type of science that you guys are doing. So I think and in terms of the sort of from what's the scope, how many NIH funded early phase clinical trials are out there in that sort of ROM mechanism. As I said, not a lot from the current from the current grant writing sort of schema, the 12-page significance innovation approach format. So working on that. There's certainly many of them have been more of the multi-center type, so that you're looking at also a different animal. So in terms of the sort of perfect animal, the early phase clinical trial in this neurological space, I've got some ideas from the people I discovered through Project Reporter. So we'll keep on looking for those so you can see some degree of an example of how this gets spaced out into 12 pages. But I think that's what I have right now on that. I think obviously there isn't a specific bulleted out background section in the instructions from the NIH and how to put together a proposal, but background information is wanted as part of that narrative that you're telling of why are you doing this and why now is the right time for what you are planning on doing. I think, Karen, so this next question I wanted to get to is, depending on what sort of mechanism you're applying to and where your grant is going to be reviewed, is there a different approach you should take to formulating your research strategy if you know that it is going to go to a dedicated clinical trials review panel versus a more general review panel?
So I'm going to take it as an opportunity to talk about the human subjects research section, because I think that becomes key. And what David just talked about right before he jumped off, this concept of you need to get them excited about your idea. That's phase one, because if you can't get them excited about the concept right off the bat and you lose them, then they're not even going to be on board enough to think as much about whether they believe you can actually get it done. But the second piece is you've got to demonstrate to them that it can not only be done, but you're the guy to do it. And so I like to think of that human subject section as our opportunity to kind of tuck that in. And so it does relate to your question a little bit, Will, which is that if you're writing a grant to a clinical trials audience, they are really looking for some specific expertise from you that relate to clinical trials. And again, a lot of that, I use the human subject section. So let me tell you a little bit about what I'm thinking. So in the method section, you have to say, number one, there's no question, you have to tell them the population you are going to enroll. You have to share with them your planned eligibility criteria, but you do not have time and space in the 12-page organization to actually describe why you're including or excluding that population. That's a place where I like to take the detail. So I put the bullet points in the body of the grant, and then I refer to the human subject section for more detail. So I've already told them it's in the guts of the grant, But for anybody who is a clinical trialist and wants to see if I really know what I'm doing, they'll go to human subjects. I'll outline the same bullet points so they can link them, but now I'm going to describe for every single one of those eligibility criteria exactly why I'm excluding those patients, why they're different, why they can't be in this trial, why they don't help me answer the question, why I'm getting rid of confounding by doing this, or I'm whatever it is I'm thinking about in a research design, a safety issue, I excluded them for safety, things like that. That kind of organization where I introduce the key concept in the body of the grant, but then describe the clinical trials components in the human subject section, I think is key when you have a clinical trials audience. And it also does what David was talking about, which demonstrates to them that I know what I'm doing and I'm the guy to do it. So what he was talking about is that recruitment section, and I think this is, other than eligibility, I would say this is the other thing that I think if you don't do this in your grant, that you're hurting yourself. You've got to demonstrate to them that you have the patient. So if you have a Parkinson's disease grant and you want to tell them that you're going to enroll 50 patients in a year, and that at your site you see 80 Parkinson's disease patients a year, and so getting 60 patients a year is a no-brainer, they are not going to buy into that. So what you've got to do is, number one, you do have to tell them that you've looked at your patient population and you know they exist. But like David was saying, you've got to then start chopping away at the total number of patients, and in stroke it is about 10% probably. But you have to think about, it's not all Parkinson's patients, right? Your eligibility criteria just told me it's only new diagnosis Parkinson's patients. So don't tell me that you have, 80 Parkinson's patients a year at your site. Tell me that only 30 of them are new onset Parkinson's patients, because that's where we're starting from. And then you're going to knock out the people that are on certain medicines, or you're going to knock out people that, have safety issues. And then you're going to cut the number further because not everybody wants to participate in clinical trials. So I strongly recommend that you do that kind of thinking out loud in the human subject section. And Will, you can talk about it too. And I know that sometimes Robert disagrees with what I say, but as a reviewer, when I review, I want to see that you thought it through, and I want to be confident that you have enough subjects. The other thing I would say is I like the idea of having a backup site for recruitment. Like David said, the number one reason these grants get in trouble in study section is because people don't believe they're going to have the patients. So if you know that that's a possibility, put in your backup plan. If by chance we still don't have enough new onset Parkinson's disease patients, we've talked to the University of Virginia. They've agreed to be our backup site, and they could potentially provide an additional 15 patients a year. So I'll stop there, and then Will, you can comment.
I think one thing that is actually illustrative, even though the sometimes you're doing that human subjects protection section a bit as an afterthought, like, oh gosh, I got my research strategy done, now I got to get all these other things. I think two things are important. Again, considering where you can reference it from your main application, but also reading the NIH instructions for the human subjects section, because a lot of it is dealing with issues of justice and research equity. And I think Karen's points about why certain populations aren't going to be included, or potentially why you may need to take extra steps to recruit particularly hard subjects to find. We've proposed a hypertension trial, and we're recruiting from the emergency department. So these are people who may be hard to find in other recruitment settings. So I think illustrating that using that, but again, the main place, human subjects protection is going to be a checkbox, yes, no, is it adequate? The other style points you'll get from the clinical trialists are, I know recruitment's going to be a problem. I want to know what these exclusion criteria are for, if these are arbitrary or these are well thought out. And that's where they can go for the additional detail. And then they'll give you back those style points. They're like, oh, why are they excluding, women? I mean, that would be, you're going to have a strong justification for that. That's, I think that's important. I think in terms of if you have a backup, I think what Heidi's question is if you're going to, let's say you're planning 3 sites, but then you have that 4th site waiting in the wings. Yeah, I think you definitely should have a letter from that site. And ideally, I think what Karen is saying, that say, well, we know they have 80 Parkinson's patients a year. Sure, great. That's admin data, right? Your hospital can pull that in 5 seconds from billing codes. Like, they really know that of these, how many people are on medication X, how many people are new onset. When you've done that, that really indicates that you aren't just guessing, that those sites have you've thought about it at those sites. They have enough organization there that they can identify the preliminary eligibility criteria, and that gives those extra points to your approach in that you've pre-thought about the feasibility, not we got 100 stroke patients a year, I should be able to get 20, right? I mean, I think that's the maybe you should, but if you can say, I think what I'm going to say from that is enrolling in clinical trials, I you're going to get there's going to be less people who are really available, and if you think pretty critically about who is available and when and to whom, I think that helps, and I think that helps you in terms of doing the clinical trial and getting patients into it, which is the ultimate goal. I think in terms of how I took it, and for budget site, you'd mostly you'd have to sort of figure it out. A lot of times, a clinical trial is going to be tied to, in a multi-center space, or it should be, per subject payments, and that's not necessarily to be coercive, but that's just to be realistic, because you can never adequately predict the proportion that each site is really going to contribute from at the beginning. It's never going to match up with what it is at the end. And as such, if sites are underperforming, then you should have more of the budget that's being dedicated to per patient costs to reallocate. If you are designing a budget for a multi-center trial, it is generally not a good approach to just give people money to have a coordinator sitting there. That's not the model that is generally used in multi-center clinical trials, because that is a potential recipe for having a lot of people sitting around not enrolling in your trial. So I think also I would just, I think we're getting here to about 3 minutes till at the end of the time. I know other people may have other commitments. Please type in additional questions or email Karen or I. I will hand the mic over to, I had a question of what is innovation anyway. I'm just going to briefly give you what I think, and maybe let Karen know too. I think that's something that trips people up a lot. So on NIAID's website, they sort of have a definition that innovation, I also heard a thing on NPR saying that innovation as a word has become sort of devalued, like, because everybody wants to be innovative these days, and it has lost its meaning because, well, everybody wants to be innovative. NIAID is in that reference I sent where they talk about how you write a research strategy from a general scientific perspective, not specific to clinical trials, highlights that by saying, when we're talking innovative, we're not talking about paradigm shifting. If you're shifting a paradigm, you're likely going to put all of the people reviewing your grant out of work by discovering something that's completely new, and they're not going to like that. And we can argue about the conservatism in science and so forth, but this is the current, this is the way the game is played currently. And I think, innovation is that what you are learning is something new, and that it is novel, and that if you're this isn't replicating old experiments, although reproducible research is important. This is, I am learning something new, and maybe I'm using a new technique to learn something new, but I'm not throwing, I'm not turning, I'm not sort of revising vascular neurology as a specialty completely in my grant. It is you are doing something new and worthwhile. You may be using a new technique or applying a new treatment. Most clinical trials you're going to be pretty okay here in terms of, presumably you're using some sort of new treatment, and at least in a new disease. I think that should be relatively easy.
Yeah, I would add to that I think innovation is not important. So don't do in that innovation section all the reasons why this should be done, why it's important, why it's significant. That's not innovation. I think of innovation as you have a new approach to this in some way. So, like, again, I hate to use my work as an example, but it's what I know. So When I think of our trial, the SHINE trial, lots of people had done glucose control acute stroke trials, but nobody had used a decision support tool to help manage the glucoses. So the concept of figuring out this question about controlling glucose in stroke was not new, but the innovation was that we were going to use some technology to help us do it in a way that was going to make the data cleaner, clearer, and help us answer the question better. So that was the innovation. We had a new approach. The question wasn't that new. It's not that it is or is not important. It's that we brought something new to the table of this research, and that's what I think of as innovation. So I'll stop there.
All right. Well, I thank everybody for their attention. I am very sensitive to your time. Again, feel free to email either of us or David with additional questions. If you don't know David Wright's email address, I can certainly get that for you, or send something and say, hey, I want all three of you to answer it. I'll forward it on to him and see what he thinks. Please do not forget to evaluate this session over here, and I hope you all have a good rest of your afternoon. And our next session is going to be, I think, on October 23rd. But you've been sent a calendar invite, and we'll be publicizing that soon, about developing a local research workforce with a lot of the team from MGH there that I think will be really helpful, as having force multipliers who can help you do your work is so important. So anyway, have a good afternoon, and thanks for your time.